Okay, friends, it is my great pleasure today to introduce to you two of our speakers today for optimizing health outcomes for older adults with epilepsy. They will be telling you about a project that has been underway in connection to our Comprehensive Epilepsy Centers and our epilepsy community here at the Epilepsy Foundation of Michigan. So I would like to introduce Dr. Rohit Marawar, who is an epileptologist at Detroit Medical Center and at Wayne State Comprehensive Epilepsy Program, and Dr. Kristina Karanec, who is an epileptologist at Trinity Health St. Mary. So I'll invite you to the stage. Thank you.
Okay, thank you, Renee. Okay, welcome everyone, and we're very excited to be here and present this very important topic, particularly as it involves the foundation and our grant in terms of bringing this topic to the attention of everyone. So we'll just get started. No disclosures. So first, why is it important that we define epilepsy in the older adult population? I think it's easy to understand and differentiate the difference between pediatric epilepsy and adult epilepsy and approach these two in different manners. But why define the young adult and older adult epilepsy population? And really, there's some very important differentiations we have to be aware of. And really, we should define this as a separate entity. The causes of the seizures can be quite different in the older population. The presentation and characteristics of the seizures can be unique and in fact more subtle and difficult to identify. And this population also typically deals with multiple medical conditions that we have to take into consideration. We have to consider the physiologic changes that occur as we get older, particularly changes with our liver and kidney function. And how do we define the older population? Typically, when we look at studies and reviews, they use the age of 65. In some cases, 60 will be used as the age. But we really should understand that this is a gradual process and it evolves over a spectrum of time rather than a discrete age. And this slide just shows that we're really an aging population. The third half is age 65 and older. The red represents the population in 2012, and green is the population expected in 2030. So we see this is going to be an increasing burden and something we really need to consider and understand. And how common is epilepsy in our older population, the epidemiology? We need to understand two definitions, the incidence and the prevalence of a disease. The incidence refers to the rate of new cases of a disease occurring in a specific population over a particular period of time, versus prevalence, which is the number of cases of a disease in a specific population at a particular time point or over a period of time. So in easy terms, that's the new and pre-existing cases. And you can see this graph. The top is the incidence, and over time, the incidence significantly increases as the age. We sort of see a peak in pediatric and early adolescence. It sort of evens out, and then we see kind of the highest peak prevalence in our older population. And the annual incidence is roughly 90 per 100,000 people in age 65 to 69, and as age increases, the incidence increases. When we refer to incidence among races, we have to understand that the Black elderly population has the highest incidence and prevalence of seizures. And this is important so that we can address this, allocate additional resources, education, and access to this population. The older population is also has the incidence twice that of our of a status epilepticus. And this is just a graph representing that. We see a high incidence in our neonates, and then again it sort of tapers off, and then we see a peak in the older population. And this is very important to understand because this is a quite serious condition of either a prolonged seizure, sort of the definition is 5 minutes or longer, or repetitive seizures where the patient continues to have seizures and they do not return to their baseline in between. The annual incidence is 86 per 100,000, and you can see the trend as you get older, the incidence also increases. The most common cause is an acute stroke, so the presentation of the stroke can be status epilepticus, and this causes a significantly high mortality in our older population, reaching nearly 50% in patients age 80 and older. It may be a subtle presentation and difficult to distinguish and diagnose, what we call non-convulsive status epilepticus. So this is not the patient who's stiff and jerking. That would be quite obvious. These patients often present in more subtle ways. They may just present with confusion, psychosis. They may be comatose, very lethargic or somnolent. And you may have a more focal presentation mimicking stroke, where they may have aphasia, difficulty speaking. They may neglect one side of their body, and this could be even in the absence of a structural abnormality such as a stroke. In one series of 236 patients of all ages, 38% were over the age of 60 without obvious seizure. So they're not twitching, they're not jerking, and they received an EEG as just part of their normal workup for coma, and 8% of those had non-clinical, non-convulsive status epilepticus. Oftentimes this occurs in the setting of acute medical conditions, such as kidney, liver failure, as a result of drug toxicity, alcohol, benzodiazepine withdrawal, and other metabolic disturbances such as diabetics with hypo or hypoglycemia, electrolyte disturbances. And the causes, what are the main causes of seizures in our older population? We have to sort of think of two broad categories. Those we classify as acute symptomatic seizures, and these are a result of an acute condition, whether it's neurologic or medical, and the seizures are provoked by this condition. In contrast to unprovoked seizures, where we don't find the underlying cause of that seizure at that moment. If you have two or more, this would meet the definition of epilepsy. So these graphs just highlight again the main causes of both acute and unprovoked seizures. Again, stressing the number one cause of acute symptomatic seizures is stroke, followed by unknown, right, other than metabolic causes. In contrast to provoked seizures, in about up to half cases, we do not find a cause, despite our evaluations, and then followed by stroke. So just going into more detail about our acute symptomatic seizures, stroke is a huge cause in our patients, mainly hemorrhagic more so than ischemic. 8% of patients with hemorrhagic stroke will develop seizures within those first 2 weeks, which fits the definition of sort of acute early onset seizure. Also included is the size of the stroke, particularly if it involves the cortex. And this is an independent risk factor for later on developing epilepsy. We now understand it to be sort of a bidirectional relationship where patients who develop epilepsy are now at a higher risk of developing stroke in our older population. And so we have to understand that and evaluate those patients for stroke risk factors and make sure that we control and treat those as well. Other acute intracranial lesions, subdural hemorrhage, subarachnoid hemorrhage, trauma, and hypertensive encephalopathy. Metabolic causes of acute symptomatic seizures, as we talked about earlier, high or low blood sugar, low sodium, particularly a sudden drop in the sodium, and acute and chronic kidney and liver disease. We also have to realize there are certain medications, and alcohol can trigger seizures, antibiotics, antipsychotics, antidepressants that sometimes are more commonly used in our older population, including things like supplements, right? Ginkgo biloba, which we sometimes think as more natural, can also be a trigger for seizures. And now the causes of unprovoked seizures. Again, up to half cases we do not know the cause, followed by post-stroke. About 20% of patients after a stroke may go on. We define this as, depending on literature, some say 7 days, a seizure occurring 7 days post-stroke, some define it as 14. But you can see after having a late seizure post-stroke, your risk of developing epilepsy is significantly increased, 71.5%. Another cause is dementia, and Alzheimer's is associated with a 5 to 10-fold increase of developing seizures. About 10 to 22% of patients with Alzheimer's will develop seizures, typically more in later disease as the disease progresses, but we also see it with early disease as well. Again, referring to provoked seizures, it's important to understand medications, right? A lot of our older population with dementia, Alzheimer's may suffer psychosis and depression, and so they are often placed on antipsychotic medications and antidepressants. And so we need to understand which of these medications are associated with higher risk of provoked seizures. And how do our older patients present with seizures? And again, it's typically more subtle than our younger adults, and this may make diagnosing and recognizing seizures much more difficult in our older population. The most common is the complex partial, or what you may now refer to as focal unaware. So the patient has no awareness of their seizure. They typically do not have an aura or sort of the pre-warning like our younger adults, the deja vu feeling, the rising kind of epigastric or roller coaster type sensation, the anxiety, panic feeling preceding the seizure. And in fact, the feeling they get may be very nonspecific, like dizziness, and that can present in a number of diseases in our older population. And it's not an unfrequent symptom that they experience. So these are all challenges in diagnosing seizures in our older population. Again, just highlighting the most common is the complex partial or focal unaware, as opposed to simple partial, where the patient maintains awareness of their seizure and they may be able to tell you about it. And this population has less frequent, what we call the tonic-clonic or the grand mal seizures. It's a less common presentation. So what may suggest seizures in our older adults? Episodic confusion, behavioral changes, periods of unresponsiveness, sudden falls with no recollection or warning, recurrent events that occur in various positions. So it's very unusual for seizures to only happen when you're standing or only happen when I change positions. And arousal from sleep with confusion or disorientation. And again, they're often hard to recognize because of the lack of warning or aura, that they have no recollection of the event. There's lack of typical motor features that we typically think of seizures, the stiffening, the rhythmic twitching. The tonic-clonic seizures are not as common. And oftentimes these patients have comorbid dementia or Alzheimer's, which may make it very difficult to differentiate confusion or behavior from a seizure versus a behavior from dementia. And they may be misdiagnosed with delirium. So again, highlighting the differences between a young adult and our older adult population. The aura is quite infrequent. The change in the awareness or level of consciousness is common in both. What we typically think of automatisms, particularly with temporal lobe seizures, hand picking, facial movements like chewing, picking in the air is again quite infrequent, and these may be very good clues in our younger adults that they may be having seizures. And another big differentiating symptom is the post-ictal confusional state. Typically it's quite brief in our younger adults, several minutes, but in our older patients this could last hours to even days, again making the diagnosis challenging. And as we highlighted before, the progression to tonic-clonic seizures is much less frequent in our older population. And when we talk about symptoms that may make you think of seizures, we have a whole host in our older population of differential diagnoses, alternate diagnoses that we really need to consider. Particularly in the neurologic world, the TIA, the transient ischemic attack, or the mini stroke, as you may hear, just transient neurologic symptoms that resolve, and it may be very difficult to distinguish, was that a brief seizure or was that due to a mini stroke. TGA, transient global amnesia, where you have just a short duration of loss of your short-term memory. May be very difficult to distinguish from a seizure or a post-ictal state. Oftentimes, metabolic things can mimic seizures, sugar, electrolytes, cardiovascular etiology, particularly syncope, which is also increased incidence in our older population. Sleep disorders can also very closely resemble seizures, particularly REM, behavioral disorder, parasomnia, such as sleepwalking, and other cardiac issues, arrhythmias, postural hypertension, right? Typically when you stand up and your blood pressure drops and you have a transient loss of consciousness. And we have to understand that our older population is also not immune to psychologically induced episodes that may mimic seizures, what we term the non-epileptic psychogenic seizures. So sometimes one of our most challenging differentiations is between syncope and seizure. And this table just gives you some highlights that may differentiate between the two. So position is quite common, right? We say you change positions, you stand, and then you have the fall with the loss of consciousness. But this is not common with seizures. The sweating and nausea, sort of the pre-symptoms of syncope, are quite common. The paleness. Unilateral symptoms are quite rare with syncope, right? So someone describes a rhythmic twitching or stiffening and then falling and losing consciousness. We should think of seizure. And the duration of loss of consciousness is quite brief with syncope and is more prolonged. You can have abnormal movements with syncope, so that is not purely differentiating between the two. They're usually brief and rhythmic, as opposed to the stiffening and more prolonged rhythmic twitching of seizures. Tongue biting is rare, and we know in epilepsy it's common, but not absolute. Frothing at the mouth, which suggests seizures. Confusion is brief in syncope, right? The patient falls, they recover, they may be confused as to why they're on the ground, but they're usually able to answer questions appropriately quickly, as opposed to the post-ictal state of seizures. And another key distinction is the movement of the eyes, typically upward with syncope and lateral with seizure. And what approach do we use in terms of trying to diagnose and differentiate this more difficult type of epilepsy? And I think we cannot stress more then a detailed history is probably the biggest clue and information we have in determining, which of course is not always possible, right? The patient doesn't remember, but you want to get the account from the patient as well as someone who's witnessed the episode. If someone is giving you a story of brief or transient confusion or behavioral changes, you should think of seizure. And also in your deferential, think about toxic, metabolic, infectious causes, which will guide your further diagnostic evaluation. If someone gives you the story of recurrent falls, then you have to also consider syncope. What in the story may guide you to syncope versus seizure, and this again will guide your further treatment in terms of, do you do a cardiac workup, a tilt table, a cardiac monitor. If someone gives you a story of memory loss, particularly short-term memory loss, then we think about transient global amnesia, and should also consider a stroke workup and a seizure workup when you get that history. Nocturnal movements can obviously, abnormal movements, kicking, twitching, waking up with confusion, but we also need to consider that these could be a sleep behavior, which is more common in our older patients, particularly with Parkinson's disease. And this may guide you then to do a sleep study. And again, it's also important to remember that our older patients can have psychologically induced episodes, and we see a higher incidence of depression and anxiety in our older population. So what are some top reasons for a misdiagnosis of epilepsy? Oftentimes the patient lives alone and we cannot get an accurate history. There may not be an eyewitness present to give additional information or details about the episodes. The patient may have cognitive impairment, right? Dementia, Alzheimer's, which may limit a good history. Oftentimes these patients start with seeing their primary care physician who may not be as familiar with what seizures and epilepsy looks like in our older population. Because we aren't familiar with the more subtle semiology, this may be a reason why seizures are underdiagnosed. But on the other side, there can be a tendency to overdiagnosis where every fall or twitch or jerk or loss of bladder control can be misdiagnosed as seizure. And furthermore, the tools, the testing, the diagnostic tools we often rely on, particularly EEG, has a low sensitivity and specificity, especially in our older population. So what we deem interictal epileptiform discharges, and these are particular abnormal waveforms we see in a routine EEG that indicates an underlying irritability and risk for further seizures. So these occur less frequently in our older adults. They're only diagnostic in about a third of our patients. In sort of our overall adult population, they're diagnostic in half, so less diagnostic. And so we then rely on more prolonged recordings, right? Whether this is our epilepsy monitoring unit to bring the patient in and attempt to record a typical spell, or at-home study where we may have a higher yield of capturing a spell in their home environment. So this is looking at one study, the VA cooperative study, that did 24-hour video EEG and showed these interictal epileptiform discharges in 50% of patients, although their routine EEGs did not show any abnormalities. And in one study, the 24-hour EEG in patients who were 70 and older who had unclear attacks, they were able to record a typical event and confirm diagnosis in 77 of 96 patients, roughly 80%. So we shouldn't only rely on the routine EEG in a diagnosis, and we should really consider a prolonged EEG. And finally, as part of our diagnostic workup, we typically do a brain MRI, especially if we suspect a structural abnormality, looking for remote stroke, diffuse brain atrophy, which may be prevalent in our Alzheimer's or dementia patients, areas of encephalomalacia or sort of shrinking and scarring, and benign tumors. Okay, I'll now turn it over to my colleague who will continue, and then I think we do questions at the end. Yeah, okay, thank you. Thank you.
Hello, everyone. Thank you for staying this late. And I see some people taking notes. That's fantastic. Okay, great. So I'm Rohit Marawar. Thank you for being here. Dr. Karanec just gave a wonderful presentation about the first half of the story of epilepsy in older adults. I'm going to carry on with the second half. The reason we are here is because Epilepsy Foundation of Michigan got a fantastic grant from the Michigan State about optimizing health outcomes in older adults with epilepsy. So this is part of our effort to educate people in Michigan about epilepsy in older adults. And so if you have epilepsy here, or if anyone else that you know have seizures and epilepsy, please reach out to them about the information that you learned here. So we heard about until the diagnostic evaluation. Now the next question is, what do we do if someone has seizures? So the next question is treatment. No one likes to take pills, but that is the best treatment we have for seizures. One might ask, if someone has seizures, why do we care about not treating, right? You would expect every person with seizures should be treated. But it's not a white and black answer. Sometimes you do have to wonder, what are the outcomes if you do treat? And if you do treat, what are unique considerations for that particular person with epilepsy that you have to take into account? And after that, which medication they should be started on? So you have to consider the outcomes of not treating and the outcomes of treating. The outcomes of not treating are, they will have seizures, they will have falls, injuries, hospitalizations, there might be loss of independence. The outcomes of treating are side effects and interaction with other medications. Pharmacokinetic basically means that once the medication enters your body, what does the body do to that medication? So with age, there are a lot of changes that happen in our body. We have decreased absorption of the medications from the stomach. There is decreased distribution, which means it's not spread as much in the body as in younger adults. Liver doesn't metabolize that as much as younger adults, and the kidneys don't excrete it as much as younger adults. Now, this happens in every single older patient. But for a particular older person with epilepsy, there is their particular genetic background, their dietary habits, their other medical condition, which we call comorbidities, polypharmacy, which means the other medications that they are taking. Now, for a particular person with epilepsy, all those things come into play. So there are some common factors, and then there are some particular factors for that particular patient. I love this quote. So it says that old age is less a period of predictable change than an increased variance between individuals. And this is certainly true. So what this is showing you is a decrease in AED clearance. Apologize for that kind of mark across the format got changed. But these are the common medications that we use in control of seizures. And what it's showing is that across most of the medications that we use, there is a decrease in clearance, which means that your body is not clearing it out anywhere from negative 20% to negative 40%. So what does that mean? That means that the levels that are in older adults with the same dose are much more inside their body as compared to a younger adult. So this is a graph that's showing a study which is specifically for phenytoin, which is a commonly used medication. But it's showing that with the same daily dose of phenytoin, you will have a much greater level in older adults as compared to younger adults. And that's because of decrease in clearance and all the other factors that we just talked about. This is a very simple experiment that was done many years ago, a study where they gave phenytoin, the same dose, to 15 individuals in a nursing home. That no other medications were changed, the phenytoin dose was not changed, but when they checked their levels every single day, they found that the level in the body in the same person varied as much as 4 times, which means that it's very unpredictable, some of these medications, what the levels will be, even without a change in dose. These are some of the other common medications that we use, carbamazepine and oxcarbazepine. What is its relation with hyponatremia, which is low sodium? So both of these medications are likely to cause low sodium, oxcarbazepine much more so. And the risk of low sodium with oxcarbazepine is also increased with diuretics and ACE inhibitors. These are commonly used medications for high blood pressure. And older adults are likely to be on these medications because high blood pressure is common. The risk of low sodium is also increased with some of the other anti-seizure medications also. This is about carbamazepine and simvastatin. Simvastatin is a very commonly used medication for cholesterol control. Carbamazepine reduces the simvastatin level in the body, which means that it's not going to be as effective. Now, if you go back to what the previous presentation said, that one of the commonest reasons for older adults with epilepsy to have epilepsy is stroke. One of the ways we protect for the strokes from happening is to lower the cholesterol level. Now, if someone is on carbamazepine and on a cholesterol lowering medication, it's not going to be as effective, which means their risk of further strokes is increased. So these older AEDs or anti-seizure medications, phenytoin, phenobarbital, carbamazepine, oxcarbazepine, they're really good at seizure control, but they're really bad at other things. So they increase the metabolism and decrease the levels of many of these medications that are, again, commonly taken by our older adults. The good news is that older adults need a much lower dose than younger adults to be seizure-free. Probably like 50% less or even 70% less. And that's a good thing, so that a lot of times their side effects are less. The other good thing is that almost 2/3 of people, older adults, they respond to the first medication that they take. This is a bigger number. In younger adults, it's usually 50% respond to their first medication, but in older adults, almost 2/3 respond to the first medication. So that's good news. Now, the question, the summary of this part is that we should avoid older medications in older people with epilepsy. I think it's just not a good combination. And if you are to start any medication, you have to start at a low dose. You have to go increase it slowly and remain at a low dose, because their target dose, the dose that will lead to seizure freedom, is usually lower than younger adults. A good news is that the trends seem to be favoring increased use of newer medications over time, and older medications are decreasing in use, but we still see that all the time, that older adults are on older medications, which is not good. The part of the problem is that many of the clinical trials for anti-seizure medications, and even in other diseases, they selectively exclude older patients because of all the reasons that we just talked about, that the levels can be very unpredictable. And in fact, another study that we did, we found the same thing, that more than 90% of the clinical trials of anti-seizure medications, they don't include older adults on purpose. If we are to start a medication, you want an ideal medication. An ideal anti-seizure medication will be completely absorbed, will have predictable change in the body, it might not be too much affected by kidney problems or liver problems, not produce too much side effects, can be easily titrated up to a target dose, and is available in a variety of formulations, right? Oral pills, liquid, IV if needed. Well, an ideal medication does not exist. But there are things that you can do to get close to that ideal medication. So is there a best medication for older people? There have been 18 clinical trials for older people with epilepsy, and these included monotherapy, which means they are on just one medication, and add-on, which means they're on multiple medications. And most compared older medications, specifically carbamazepine, with newer medications. But there are limited head-to-head trials of newer medications. So if I'm seeing a person with epilepsy in my clinic, I want to know out of these 2 or 3 newer medications, which one is the best one. I don't want to compare new with old because I don't want to start the old ones, but I want to compare new with new. And unfortunately, we don't have a lot of information. But the data that we have suggested that for seizure freedom, that's for seizure control, levetiracetam, which goes by the name Keppra, is better than lamotrigine, which goes by the name Lamictal. And Lamictal and carbamazepine were similar. For adverse effects, like side effects, lamotrigine or Lamictal was the best. So this is starting to give us some idea on what to use. There was another systematic review which just looked at monotherapy, that is, its single medication being given, and they found that carbamazepine was worst for side effects, which was expected, but the other medications, the efficacy was overall the same. However, when they did some advanced analysis, they found that lacosamide, which goes by the name Vimpat, was the best, followed by Lamictal, followed by Keppra. So these were the 3 best medications that they found for seizure freedom. Now, what are about the newest medications that have come to the market in the last 10 years or so? So these are perampanel, eslicarbamazepine, and brivaracetam, and reasonable evidence suggests that these are safe and effective in older adults. All of our older adults are on a lot of medications. A quarter of them are taking 15 or more prescribed drugs. And we know that with treatment, adherence decreases and side effects increase as you are on more medications. So if you are to see a multidisciplinary clinic which specifically treats older adults with epilepsy, this is what you would like to see. You have a social worker to address all their social needs. You have a neuropsychologist that can treat them or at least diagnose them for anxiety, depression, memory problems, a pharmacist that can help with all the medications, a geriatrician, like a primary care doctor for older people, and an epileptologist. Another good thing is that an older adult a bad thing is that people who have first seizure are more likely to have a second seizure, and that's likely because of the underlying reasons why they're having seizures, stroke being the most commonest one. So usually after a first seizure in an older adult, they are more likely to have a second seizure if stroke is specifically the underlying reason for the seizures. So what are the strategies for successful treatment? Again, start at a low dose and increase slowly. First target dose should be low. Choose once a day medication if possible, because that increases adherence. You are less likely to forget it. You avoid medications that interact with other medications. You avoid medications that cause memory problems, that can worsen behavior if someone has dementia. And you should confirm that there is some support that the person has for medication management. And you should also assess barriers to adherence and address them. And this is something I like to do always. We should follow up often and closely, because there are many occasions when the instructions are misunderstood or there are a lot of side effects, so medications are stopped and physicians are not informed. So I always like to kind of follow them closely, at least initially. Okay. Moving on to a somewhat separate topic, we were talking about memory, and epilepsy and dementia is an important thing to consider. We know that epilepsy and Alzheimer's disease go hand in hand very commonly. In fact, there is 6 to 10 times increased risk of seizures with Alzheimer's disease as compared to those who do not have Alzheimer's disease. The complex partial seizures, where they stare and don't respond, those are the commonest type of seizures in these people. This is a study from around 10 years ago. To kind of simplify it, they had an interesting question. If someone has dementia or Alzheimer's disease and also have seizures, what is the relationship between when their seizures start and their memory problems start? And they found that the seizures and the memory problems start around the same time, which is interesting. So the hypothesis is this. Alzheimer's disease has 2 abnormal proteins, amyloid and tau, that are deposited in the brain at an excessive level. We know that amyloid is deposited in the brain years and decades before the Alzheimer's disease starts. But it looks like the deposition of the tau protein is what leads to this kind of trigger, which leads to memory impairment and also seizures at the same time. This was kind of touched upon, but we do need to have multiple EEGs or long duration EEGs to increase the sensitivity of diagnosing seizures. The unfortunate thing is that these abnormalities are not specific for seizures in people with Alzheimer's disease. Even people who do not have seizures but have Alzheimer's disease can have positive or abnormal EEG. And so it becomes very tricky sometimes about regarding diagnosing epilepsy. Also, people who have epilepsy plus Alzheimer's disease, the onset of memory problems and the diagnosis of Alzheimer's disease occurs much earlier at a younger age in those who have seizures. This was an interesting study where they basically had many patients with Alzheimer's disease. Some of them had abnormalities on EEG, others did not. They compared those 2 groups as far as memory is concerned, kept on checking their memory every few months for 5 years. And they found out that those who had abnormal EEG, their memory declined much faster as compared to who did not. So this leads to conclusion that seizures or epilepsy are correlated with more severe dementia and earlier dementia also. So the question is it a cause of seizures? Is seizures leading to dementia? Is dementia leading to seizures? The answer is likely both. So there is this kind of bi-directional relationship and a vicious cycle that one is worsening the other and the other is worsening the first. We know that when there is no clear etiology, no clear reason of having new onset seizures in older adults, so that's called cryptogenic, that's almost 50%. So what's going on in these people? This study done at VA, they compared people who had late onset seizures of unknown etiology, that's the LOSU. Basically, they had seizures started at their old age but had no clear etiology. They followed them for a while, and they found that those who had no etiology ended up developing dementia at a far higher rate, which means that likely seizure is the first symptom of dementia in some of these people. They seem to be, however, very well controlled on medications, and that is a very good news. The medications that are used for Alzheimer's disease for memory control, they do not seem to affect the seizures. We don't really have a good study of using anti-seizure medications in Alzheimer's disease. There is a single study, and that was not a clinical trial, it was an observational study, and they did not find any difference between any of these medications, which was levetiracetam, Keppra, phenobarbital, and Lamictal, with regards to seizure efficacy or side effects. But they found that for memory, levetiracetam was the best medication, and for mood, lamotrigine or Lamictal was the best medication. So another study, this was published last year, then considered, is Lamictal actually good in people with Alzheimer's disease? Like, does it actually help with memory, irrespective of the control of seizures? And it was a small study of 34 patients, but they gave levetiracetam very low dose to all of them, but it did not affect if they looked at the whole population of the study, it did not affect the memory. But when they selectively looked at people who had seizures or abnormal EEG, levetiracetam did help some aspects of their memory. So the question is, why don't we just start everyone on anti-seizure medications if it helps with memory? Because there's the other side, right? What's the outcome with treating? And the outcome with treatment is that there can be a higher risk of death in older people if they're on anti-seizure medications, and that risk is worst with valproic acid, also called Depakote. So it's not just Alzheimer's disease, but other dementias also. So DLB is dementia with Lewy bodies, and FTD is frontotemporal dementia. These have a very high occurrence of seizures also. Almost 15% of these patients will have seizures 15 years after diagnosis of dementia. So, to the take-home points, polypharmacy, that is multiple medications and multiple other medical conditions, have a significant impact on the choice of anti-seizure medication. We should avoid older AEDs. Based on the available evidence, levetiracetam, lamotrigine, and lacosamide are likely the 3 best medications if you combine efficacy and safety. Concurrent dementia and epilepsy is common. Seizures or its biomarkers, that is the abnormal EEG, possibly contribute to worsening of memory in dementia. Coming back to this point, so I had pulled up a graphic of what is an ideal older adult epilepsy clinic looks like. So that's been my goal for the past 3.5 years. So this is kind of a plug, I guess. This is what I've been doing for the past 3.5 years. So it's a specialized multidisciplinary older adult epilepsy clinic that I do every Wednesday. We have a social worker, we have a neuropsychologist, a pharmacist, and then myself. The pharmacist and myself see every patient. Social worker, the patient can see the social worker if they need to, and then we have a neuropsychologist on hand for subsequent appointments for memory and other things. There is a phone number there if you guys want that, and there is a QR code with the link to the website. That's everything that I had. Thank you very much, and thank you for your attention.
Wow, that was great. There was a lot in there that I learned for the first time, and I'm very grateful. I will be going back and watching that presentation again. And just to let you all know, that was being recorded as well and will be shared, so that will be available. So very, very grateful. Let's give them another round of applause. Great. So it is time for your questions, and I have a few questions too if we need some more, but I see a hand all the way up here with Jackie Carnes, and Jillian is coming. Yeah, but we might be able to, they may need it. Okay.
So I immediately had a question as soon as you guys started your presentation, which I appreciate the really focusing on the connection between epilepsy and dementia, epilepsy and Alzheimer's. I have the question, and I'm in the position of, my mother has had epilepsy since she was a teenager, so she's been on all these different epilepsy drugs for years, every day, multiple times a day. They prevent her grand mal seizures, but she still has petit mals every day, absent seizures every day. My fear and my question is, I've seen a significant decline in her memory, either due to the seizures or the medication. So she's not having seizures due to dementia. It is the opposite. I fear, do I need to look out for dementia and Alzheimer's due to her epilepsy and these medications that she's been taking for decades?
Yeah, great question. So we know that we talked about how Alzheimer's disease increases the risk of seizures, but it's the other way around also. A lifelong history or a chronic history of seizures will increase the risk of dementia, unfortunately. So, but in someone who is having frequent seizures, the question is it the seizures that's causing the ongoing memory problems, or has seizures led to irreversible change in the brain that's causing the memory problems? So I would say that the best way to kind of go forward would be to find out what is the seizure burden right now. And sometimes, as we discussed, the seizures can be very subtle. And sometimes just like staring and what we would call daydreaming, those might be seizures. So like a prolonged EEG or like an epilepsy monitoring unit admission. So those would be to figure out what the seizure burden is, minimize that seizure burden, preferably lead to seizure freedom, and then there will be a better idea about what's causing the memory problems. So that would be my answer.
We have a follow-up question. Would you mind bringing it back?
So really quickly, yes, yep, she's already done the epilepsy monitoring unit for 5 days. We pinpointed it, and I'm her primary caregiver. She lives with me. We have seen a significant decrease in her cognitive function and her memory, and discuss with her doctor, what specifically should I be looking for to pinpoint dementia or Alzheimer's symptoms?
Usual symptoms are just forgetfulness. I mean, if you're specifically talking about Alzheimer's disease, it's short-term memory loss, forgetting conversation, repeating questions, misplacing things, getting lost while driving or walking, not able to or needing help with paying bills, needing help with cooking, those kind of things. But again, there might be other things also. Sometimes, we can't really just assume it's dementia, because there can sometimes be reversible causes, sometimes thyroid problems, vitamin deficiencies, sometimes just being on medications, being on a laundry list of medications can cause memory problems. Anxiety, depression can cause memory problems. So I think we can't just assume it's dementia. But if you're seeing some of those symptoms, then definitely next step would be to kind of talk to your neurologist about your concerns and go from there.
Mm-hmm. Yeah, and could a primary care physician be good at coordinating, some kind of diagnostic around? Because I could imagine a situation where you're like, I'm seeing it, but I just don't know which it is. Like, what do I do?
Yeah, I mean, I think, primary care would be a good place to start, but I think unfortunately, they might not be able to, with the complexity of, both of these chronic conditions going on, they might not be able to tell you or pinpoint what's going on. So, a referral to a neurologist if you already don't have one, or even an epilepsy specialist would be the next step.
Wonderful, thank you. And that's a good example too. We've talked today about appropriate epilepsy care. When do you need to see a specialist? And this could be one of many other reasons that it's a great idea to get connected to an epileptologist and a comprehensive epilepsy center. I see a question with Michael.
Listening to what you were showing on your thing, I take 2 of the medications. The first one I don't take. The one I do take is lacosamide and lamotrigine. But the first one, is that LEC?
Levetiracetam or Keppra.
Okay, you know how to pronounce it, I don't. What is that? Is it a separate drug? Maybe you can answer that better.
No, you.
Yeah, it's a drug that has a different mechanism of action as compared to lamotrigine and Vimpat. So it's a completely separate drug, separate mechanism of action. Again, as you already know, as all of us know, unfortunately, no one can predict who is going to respond to which medication. That is one of the unfortunate things that we haven't figured out in epilepsy. Yeah.
Okay, there was a follow-up question I had to ask, and this doesn't have to do with that. When I was at church, or when I'm at church, once in a while, it happens. Nobody around me knows it happens, but it happens.
Do you mean a seizure?
Yeah.
Yeah. Mm-hmm.
I think we've gone back and forth without that, Renee.
Sure.
That people, I know what's happening. They don't know what's happening. I could be sitting next to you, and it could happen. Mm-hmm. But nobody knows except for myself.
Sure, and I think that's true for a lot of people. I mean, sometimes some types of seizures are truly invisible. They might just be a feeling or experience of deja vu or it's just a funny feeling, but also sometimes even with motor symptoms, it can be so subtle that a lot of people don't know to notice, or absence seizures go unnoticed and a lot of people too. And we may have another question back there, I'm not sure. In the meantime, right here, okay.
To the panel, could you teach me the difference between an EEG and a video EEG? And one more question. You use the term linear pharmacokinetics as far as pharmaceutical evaluation. Could you teach me what that term means also, linear pharmacokinetics?
It might not be.
Okay. I'll address your question regarding EEG. So video EEG just incorporates the use of the video, right? Which I think now has become pretty standard. Even on our routine EEG, usually we have the video to try to capture clinical events or symptoms. When we differentiate long-term or continuous video EEG, then this is our prolonged studies where we either bring you into our epilepsy unit and record over several hours to several days. It can also be a home study, what we call an ambulatory EEG. And now the technology really lets us have pretty good high-quality video data with our home studies.
Thank you. I had a question, and this is a question about caregivers. I'm curious, in older age, for those who are serving as caregivers, whether they're spouses or adult children, friends, how can we best support caregivers? What are some of the things that you hear from them that they need, and how can a community surround them?
So I think, first of all, there is a lack of awareness that older people can have seizures. Mm-hmm. And this is part of our effort to change that, right? Along with the grant quality initiatives that we are doing. But if you already know that your loved one who's an older adult has seizures, I think just helping them with day-to-day things. I think the biggest thing that I realize is that the caregiver assumes that the person with epilepsy is able to manage their medications, which is not true. Even though they might not have obvious memory problems, the medication regimens can be complex. Sometimes people just get tired of taking medications. So to provide that support, to provide the encouragement that if you do take medications, many of our older adults with epilepsy, they will have good control of seizures. So that's a good point as compared to our younger adults with epilepsy. Besides that, just being observant about funny episodes, staring off, not responding, kind of a rapid change in their mental status, like 1 minute they are okay, the next minute they are confused, and those can be all seizures. Keep an eye out on gradually worsening memory over a period of months to years, because that might herald the onset of either dementia or medication side effects sometimes. Depression is very common in older adults with epilepsy, a lot of times because it's of social isolation. They are not working, they're not driving, sometimes the family is not with them. So I see that a lot. So I think providing just support and being more observant. So one thing I should always add, that please come to your loved one to the clinic. Because there's a lot of information that we cannot get as physicians if there's no one there to provide that information.
Thank you. And I would just say I'd love to hear from caregivers as well, like in the weeks to come, how can we support you on that journey? And also to let you know, like this wonderful clinic that's happening on Wednesdays, we also have an older adults with epilepsy support group. It's called our Call and Connect group, and it's older adults with epilepsy and caregivers. So we have space for them specifically. That group meets on Wednesdays from 4 to 5 p.m. and is a lovely community. So I see a question here.
Yes, I am a caregiver, and I care for a 19-year-old at this point. And I've been hearing about different type of seizures all evening, you know, the frontal and the lobe, whatever seizures. Is there a seizure that comes from the top of the head? Because he holds his head all the time, and he rubs it. And I'm wondering if he's having headaches, because he's nonverbal, so, you know, I don't know. And I just be speculating the fact that maybe he's having a headache, you know, but he just rubs it all the time. And so I'm like, is this something that's indicate that he's gonna have a seizure, or what's going on with him?
Yeah, I think that's very challenging, right, in our patients who are nonverbal and can communicate their feelings or sensations. And you know, pointing to a specific part of the head doesn't suggest that that's where the seizures are coming from. I don't think that's necessarily the case. I mean, you definitely can have seizures originate from really anywhere, right? Even in the central, kind of what we call the central lobe. And so understanding the types of seizures that originate from different lobes may be helpful. In this instance, maybe it would be useful to get the prolonged EEG, right, where we record, especially if this is a common phenomenon for him. And that may help you guide saying, well, is he feeling something? Is it more of a pain? Is he trying to express something and not necessarily seizure related? So I think if you came to me in the office and said, you know, this is happening, I don't know how to interpret it, could this be seizure? I would tell you, I don't know, but if it's frequent enough that we may be able to record it and capture it and really figure out that answer before just increasing medications or saying we don't know, that would be my approach.
Thank you. Yes, Nadia Van.
Hello, I have a question. We've been talking a lot about coordinating care and making sure that everyone is, that the stakeholder is a part of it. One of the barriers that I find that a lot of caregivers have is being able to get information back. So when you're saying, please come to these appointments so that you can give us information, but then the caregivers call and they can't get it back. So what are your recommendations for how to close that information loop so that everybody knows what's going on?
So usually, you know, as I said, you know, it's not just one way, right? If someone is coming to the clinic, caregiver, then it's a two-way street. We are getting information, and they are getting information from us. So it's important for that reason also. But what I usually do is, if there's no one with the patient in the clinic, I always make a phone call to one of, you know, whoever they want to call, like whoever knows them the best. That's kind of a standard practice for me, because I do want to get more information. And, you know, if they have any questions, then I can answer that also, because I cannot, unfortunately, trust that the patient will relay all the information. You know, obviously we are available by phone and email and those kind of things. Once in a while, I also give out my email, because I know that communication has many barriers in a hospital. So depending on the situation, you know, sometimes I give out my email. Obviously, there are now email communications available through the EMR also. We don't have that, so that's why sometimes I give out my email. But yeah, I think that would be it. Plus, you know, we usually hand out the like the FAQs that we generated as part of our QI initiative here. So we usually hand those out to the patients to give to their caregivers also. But, you know, I think one of the things that we probably should be doing is, you know, more talks like this, websites, videos, because those are the common modes of communication nowadays for people to understand about this. You know, yeah. I think I did not answer the gentleman in the back's question about pharmacokinetics. You were asking about linear pharmacokinetics. What does that mean? So linear pharmacokinetics basically means that if you take a medication at a particular dose, the response to that dose will be predictable. So for example, I'll give you a common example. If you're taking Keppra at 500 milligrams twice a day, there will be a particular level. If you double that dose, the level will be, you know, approximately double. So that's linear pharmacokinetics. But it doesn't happen with certain medications, and the one that's notorious for not having linear pharmacokinetics is Dilantin. So a doubling of the dose of Dilantin will lead to 3 times or 4 times or even 5 times the level. And you don't want that because that's unpredictable. In fact, I just saw a patient this morning in the clinic, in the ER, who was having Dilantin toxicity because he doubled his dose by himself, and now he can't walk, he's dizzy, he's now having nausea and vomiting. So, again, not to harp on the same thing again, but that's why I don't like some of these medications. Sorry, you had another question?
You mentioned one medicine that has a linear, what do you want to call it, pharmacokinetic, and then some have exponential scales that the liver can only process and the kidneys can only process so much, apparently. Are there other medications with a very exponential chart of the body's ability to eliminate that from your system?
So Dilantin is the worst in that regard. So that has the exponential pharmacokinetics. Some others which are a little bit unpredictable in older adults are valproic acid or Depakote and carbamazepine. So these are bound to proteins in the body, and if you have low proteins, which a lot of older people do, then they have free versions of those medications floating through the body, and that can lead to unpredictable side effects. So those would be the 3, Dilantin being the worst of them. Most of the newer medications, let's say since the year 2000 that we've had, they all have predictable and linear pharmacokinetics.
Thank you. Well, we are just about out of time, but I want to finish up with a variety of gratitudes. One is for our grant funder that has been funding this grant called the Optimizing Health Outcomes for Older Adults with Epilepsy, and that is the Michigan Health Endowment Fund. And I'm grateful for Tori Allen, who is our program contractor, who is leading this grant that is involving quality improvement and in partnership with our comprehensive epilepsy programs. And of course, I especially right now want to thank Dr. Karanec and Dr. Marawar. Please join me in a round of applause.